Hi everyone, my name is Shelby. I am one of the PGY1 first year ambulatory care residents at Cone this year, and my co-resident Ivy, who is the PGY2 second year ambulatory care resident, will be presenting on diabetes management. I'll be presenting on the first part and then she'll be presenting on the second part. So I will be talking about in this first part an introduction of diabetes and then reviewing all of the non-insulin therapies. My objectives for this presentation are to explain the mechanisms of action of different anti-diabetic drug classes, recognize the adverse event profiles for common diabetes medications, and then in part 2, Ivy will discuss the agents for hypoglycemia management, and then compare and contrast CGM devices available for use. The general outline of this presentation includes a diabetes introduction and background review, a review of the American Diabetes 2022 Guidelines Review, and we'll discuss the different anti-diabetic agents, including non-insulin and insulin agents. And in part 2, you'll review the insulin agents with Ivy, and then she'll also cover treating hypoglycemia and continuous glucose monitoring, or CGM. Now we'll talk about an introduction in diabetes. Diabetes is a chronic metabolic disease characterized by elevated blood glucose levels, which can damage the heart, vasculature, eyes, kidneys, and nerves. Normally, the hormone insulin is made by beta cells in the pancreas, which help regulate how much glucose is in the blood. Insulin stimulates the cells to absorb glucose from the blood for energy and the liver to store excess glucose. In type 1 diabetes, the immune system attacks these beta cells, which leads to a beta cell deficiency and thus an insulin deficiency. In type 2 diabetes, it is rather a relative deficiency of insulin rather than a complete deficiency like in type 1. So in type 2, the body is unable to produce an adequate amount of insulin to meet the needs of the body. Insulin resistance also develops, likely due to changes in insulin receptors, and obesity is usually the main cause of insulin resistance. We won't dive that much deeper into the pathophysiology of diabetes, but it is important to understand this, as a lot of the medications will help to modify or improve this setting to help manage diabetes. Diabetes is an increasingly common disease state, something that you'll see very frequently in a primary care setting. It's a leading cause of mortality in the US, as you can see here in the slide. It is included in the list with other commonly thought of mortality factors like heart disease and cancer. And it is also important to recognize that diabetes increases the risk of heart disease and cardiac death compared to patients that don't have diabetes. So definitely something that we want to take very seriously and help manage to the best of our ability to decrease any morbidity and mortality from diabetes. Luckily, we have a lot of tools, including very well-studied guidelines and many medications that we can use to help improve the outcomes for patients with diabetes. So next we'll go through that. The American Diabetes Association guidelines give recommended glycemic targets, and most commonly we target the A1C as well as the preprandial blood glucose and peak postprandial blood glucose. For the A1C, that's a measure of their average blood glucose over 3 months, and the general goal is to be less than 7%, and this helps to reduce any negative outcomes we're trying to avoid with unmanaged diabetes. And this is recommended to be checked twice per year if a patient is within that goal. However, if they're not, then it's recommended to check that quarterly or every 3 months. For preprandial blood glucose, that's essentially meaning before a patient eats. So this would be their fasting blood sugar, typically checked when they wake up in the morning. And the goal would be between 80 to 130, or generally less than 110. And then the peak postprandial blood sugar, or blood glucose, is the highest blood sugar that they're going to have after they eat a meal. And this is typically measured 1 to 2 hours after eating, and this goal would be ideally less than 180. Of course, your blood sugar goals will change if your A1C goal changes, which I'll talk a little bit more about that on the next slide. I also wanted to mention that the ADA guidelines, which is updated every year, most recently updated in 2022, now recommends that adults who do not have diabetes symptoms should be screened for prediabetes and type 2 diabetes starting at age 35. And this comes from the U.S. Preventative Service Task Force, which lowered its recommended screening age from 45 to 35 in August of 2021. So a lot of patients will be indicated for screening, and then once they are diagnosed with diabetes, then they would be looking to target these glycemic goals. About 1 in 5 U.S. adults with diabetes are currently undiagnosed, so there's a lot of room for improvement in identifying patients that have diabetes and are not aware. So this graphic comes from the American Diabetes Association guidelines, and I find it very handy to give a visualization of how the A1C target is more of a flexible patient-specific goal rather than everyone having a less than 7 goal. So this is something that you should modify based on patient factors. So if a patient is not able to safely reach a less than 7% goal, then it's very reasonable to target a higher goal like 7.5 or less than 8, or in some cases less than 8.5. Some things on why you might want to target a less stringent goal would be if a patient is experiencing a lot of hypoglycemia despite all the management techniques. They've had diabetes for a very long time, which makes it more difficult to control as they've continued to develop insulin resistance and increased their insulin deficiency over time with their beta cells not functioning as well. If they have a very short life expectancy compared to others, or have a significant or severe amount of comorbidities or vascular complications, making it difficult to manage their diabetes at such a strict level. Patients may also have a preference for less intense or less burdensome therapy, or they may not have the resources or support system in obtaining medications or being able to safely use their medications and use them correctly with good adherence. On the other side, if a patient has kind of basically the opposite of those situations I just described, you may more easily target an even stricter goal. As long as you're able to obtain it safely, you could target a lower goal to obtain better benefits in preventing any kind of comorbidities or adverse effects from elevated blood sugar. Once a patient's A1C goal is determined, it doesn't have to stay that way, and things like this can change over time depending on the changes in their other disease states or other factors that you may want to consider. It should be clear, though, when you are following a patient with diabetes, what your A1C goal is for that patient, so everybody is on the same page as to what goal you're targeting. Now we will discuss the ADA 2022 guidelines. I know this graphic can seem pretty overwhelming at first if you've never seen it before. They do update this a little bit every year, so this is the most new updated version, but I will walk you through each part and point out the pharmacotherapy options as we go through and when different options are indicated for patients based on the guidelines. As you can see here, there are a lot of different diabetes medications, and it can be overwhelming to be able to understand and associate which medication is with which brand name or which drug class. Definitely encourage you to spend some time with this information if you can, whether it's making flashcards or reviewing the material to become more familiar with which drug is within which class. It can also be helpful to recognize some patterns. Mainly, a lot of these end in the same ending or suffix within the same drug class. For example, GLP-1s all end in tide. However, you'll know that brand names are more commonly used with a lot of these, as many are only brand name, so you'll need to be able to recognize those as well. In 2022, the ADA modified its recommendations on how to manage diabetes-related complications, including heart failure, CKD, obesity, retinopathy, and more. The new four-pronged approach for people with diabetes is to help reduce the risk of developing these complications. And as you can see here in this graphic, the four pillars include glucose management, blood pressure management, lipid management, and using glucose-lowering medications that have been shown to have heart or kidney benefits, all on top of a lifestyle modification and diabetes self-management education and support. So essentially, this entire graphic is kind of the goal of treating the overall diabetes patient to help give them the best outcomes. The new guidelines recommend an individualized approach from the moment of diagnosis of type 2 diabetes, and this means taking into account the goal to prevent complications like heart or kidney disease, cost, access to care, and individual management needs. While the guidelines still recommend that the first medication should be prescribed, usually should be metformin, in addition to comprehensive lifestyle changes, this new recommendation allows for more flexibility than the prior recommendations, which said that all people should be prescribed metformin. Metformin is still a good drug, but it should not be a deterrent to start medications that we know will be effective to help reduce cardiovascular effects or renal risk. There are other medications that may be more appropriate earlier, and these change in recommendations is meant to encourage clinicians and providers to start these earlier in the process rather than waiting until a patient needs something in addition to metformin. Despite all that I just said, metformin is a really affordable medication and a lot better tolerated than some of the other low-cost medications, which makes it a really good option for first-line therapy still, especially if a patient doesn't have any compelling indications, which we'll go through with the other drug classes and what those indications might be. But first, we'll talk about metformin. So metformin works by decreasing the hepatic glucose production, which decreases intestinal absorption of glucose and improves insulin sensitivity by increasing the peripheral glucose uptake and utilization, essentially increasing insulin sensitivity and decreasing gluconeogenesis and glucose absorption, as you can see in the graphic. The efficacy is pretty good. It decreases the A1C by 1.5 to 2%. As we go through these, you'll see that that's pretty good compared to some other medication options, especially if you have a patient that is with an A1C greater, in the higher ranges of 8, 9, they're likely going to need something in combination rather than one agent. So this is a really good option to help get them closer to goal. It also helps to decrease the basal and postprandial glucose levels. Metformin does have renal dose adjustment requirements, so it's important to be monitoring through eGFR specifically. And it's recommended that if a patient has an eGFR less than 45 to not start metformin, and if they're already on it, to consider a dose reduction. And if they have an eGFR of less than 30, the use is contraindicated. So if they're already on metformin, they should actually have that medication be discontinued. Metformin comes in both immediate and extended release formulations. The initial dosing is around 500 to 1,000 milligrams per day, with a max dose of around 2,000 milligrams per day. Although the max for the immediate release is listed as 2,550, there is no extra efficacy with doses this high, and the max should really be about around 2,000 milligrams per day, since going beyond that is just going to give patients more risk of adverse effects without an additional benefit. When titrating metformin for a patient, the dose increases should be made by 500 milligrams per day, and that should be changed every week. So if you're starting a patient on 1,000 milligrams per day, then increasing to 1,500 milligrams the next week, and then 2,000 milligrams per day the following week. The cardiovascular benefit that is seen with metformin is seen at the dose of 1,700 milligrams per day. The extended release version is really useful to help decrease the risk of adverse effects that are commonly experienced with metformin, although it depends sometimes on affordability on which agent is selected. The common side effects for metformin include GI upset, which includes nausea, vomiting, and diarrhea, and flatulence. This can be managed by titrating the medication slowly, as well as using the extended release that I mentioned, which is better tolerated than the immediate release. Less common potential side effects include a vitamin B12 deficiency, which is mainly only with chronic use, and you can consider a periodic assessment, especially in patients that have anemia or peripheral neuropathy. And if a patient does have B12 deficiency, this can just be supplemented with B12. It may also lead to folic acid deficiency and can consider an assessment of this if a patient has megaloblastic anemia. Some serious but rare potential side effect is lactic acidosis, and this is when the lactate is greater than 5, usually with a pH of less than 7.35 and an anion gap of greater than 14. This is important to keep in mind and help prevent by adjusting those doses based on eGFR to help prevent this from happening in the first place. Moving through that large diagram or algorithm from the guidelines, there is a list of medications that we should consider independently of baseline A1C, an individualized A1C target, or metformin use. Essentially, what kind of comorbidities does our patient have, and is there a medication we could put them on to help decrease their risk or help better manage those comorbidities along with their diabetes. These disease states include ASCVD, heart failure, and/or CKD. There are only certain medications that have shown in clinical trials to have benefit in these disease states, and that includes these GLP-1 receptor agonists and these SGLT2 inhibitors. The medications that are bolded have clinical trial data showing ASCVD risk reduction, mainly for a MACE outcome, which is defined as a composite of total death, myocardial infarction, coronary revascularization, stroke, and hospitalization because of heart failure. The SGLT2s on the right also have positive CKD and heart failure outcomes data specifically, and we'll go through more of this in the following slides. First, we'll talk about the GLP-1 receptor agonist drugs. Here, I've pointed out the different areas in this diagram or algorithm where GLP-1s show up. So under ASCVD or indicators of high risk, GLP-1s are recommended, specifically the ones with proven cardiovascular disease benefit. And I will go through which ones have that benefit in the following slide. We also see on the right for CKD, GLP-1s are a recommendation instead of SGLT2s if there isn't an SGLT2 that can be tolerated or is contraindicated for a patient. And they also recommend the agents that have proven cardiovascular disease benefit. And for patients with CKD without albuminuria, they recommend either a GLP-1 and or an SGLT2 to help decrease cardiovascular risk. GLP-1 products are injectable pen devices, so this is important to consider when considering selecting this medication for a patient, as it will require the patient to self-administer the medication, similarly to insulin, but also has different factors that are important counseling points to go over with patients as well. Some common ones, as you'll see here, include Victoza, Trulicity, Ozempic, Byetta, and Bydureon. So how does the GLP-1 receptor agonist work? So GLP-1 or glucagon-like peptide 1 is a hormone that's released from the intestinal tract in response to food. GLP-1 has many effects in the body as shown in the image on the slide. GLP-1 binds to the GLP-1 receptors on the pancreas to increase insulin secretion and reduce glucagon secretion. It also binds to the receptors in the stomach to slow gastric emptying, receptors on the brain to decrease appetite, and the liver to reduce glucose production, and muscle and adipose tissue to increase glucose uptake and storage. So how do these medications work? So these are GLP-1 receptor agonists. So they bind and activate the GLP-1 receptor, which essentially acts like endogenous GLP-1. Thus, they enhance the insulin secretion and they slow gastric emptying. Because of its mechanism of action, insulin is only secreted in response to food entering the GI tract. Thus, there is no increased risk of hypoglycemia except when it's used with medications that increase insulin sensitivity or used with insulin itself. The efficacy is also pretty good. It helps decrease the A1C by about 0.5 to 1.5% and decreases postprandial glucose. Its place in therapy is for patients that have established ASCVD or high risk. They want to help decrease their CKD progression, and it's also preferred over insulin if an injectable therapy is needed, which is mainly when a patient's A1C is greater than 10%. And these medications also promote weight loss by helping provide early satiety or helping a patient feel full earlier when they're eating, and thus can be beneficial to help promote weight loss and then better manage diabetes by helping manage obesity as well. Some of the GLP-1s are administered once a week, whereas others are administered once a day. So these medications are given once weekly, including Ozempic or semaglutide, Trulicity or dulaglutide, and Bydureon or Bezice, which is exenatide extended release. And these also have different dosing levels that are titrated by every 4 weeks, as you can see here. And they also come in different dosage forms. So for example, the Ozempic pen comes as a pen similar to insulin where you have to dial it or titrate it up to the dose. However, other medications like Trulicity come as an auto-injector, which does not require the patient to dial it up or administer it in a way similar to insulin in a pen. It instead auto-injects, so it can be easier for patients who have needle phobia. And here are the medications that are given once a day. Also, we have different dosing titrations and are titrated either every week or every 2 to 4 weeks, and these all come in a pen form. These include Victoza or liraglutide, Byetta or exenatide, and Adalimumab or lixisenatide. GLP-1s, as I already mentioned, have a lot of benefits. So the specific medications that have shown cardiovascular disease benefit, as mentioned in the guidelines, include Ozempic, Trulicity, and Victoza. The medications have also been studied to compare weight loss efficacy, and so I've listed here which are the most effective for weight loss to least, which includes Ozempic with the most benefit in weight loss. If you're familiar, these medications can also be used for weight loss alone for patients that don't have diabetes and come in a different brand name. So these are very effective medications to help promote weight loss in your patients. These medications also provide renal protection, and this includes in studies shown to reduce nephropathy, reducing the progression of CKD, and reducing the rate of eGFR decline, which includes Ozempic, Trulicity, and Victoza, the same medications that have cardiovascular benefit. And lastly, all of these medications help lower the risk of hypoglycemia compared to other agents like insulin or promoting insulin secretion medications. The common side effects of GLP-1s include nausea, vomiting, and sometimes diarrhea. This is why it's really important for these medications to be titrated up slowly to help reduce the severity and improve tolerance. Patients should also be counseled to eat smaller portions due to these medications causing early satiety and slowing gastric emptying. Other possible side effects include injection site reactions. These medications may also increase the risk of pancreatitis or cholelithiasis, and commonly it's recommended to avoid GLP-1s in patients that have a history of or currently have those conditions. In addition to that, there's a rare risk of multiple endocrine neoplasia type 2. So this is a contraindication in patients that currently have that disease state. Lastly, this medication class has a black box warning for medullary thyroid cancer and should be avoided in any patients that have a history or currently have medullary thyroid cancer. This warning is due to thyroid C cell tumors that were observed in rodents. However, there hasn't been any evidence of this occurring in humans since these medications have been on the market, but it's still recommended to avoid as a complete contraindication in patients that have a history or currently have that. Some of these medications do have dose adjustments based on renal function, including Byetta or Bydureon, which are recommended to avoid with a creatinine clearance of less than 30, and Adalimumab is recommended to avoid with a creatinine clearance of less than 25. Ribelsus is a new GLP-1 receptor agonist that actually comes in oral form, and this is the specific medication semaglutide, which in the injector form is called Ozempic. So Ribelsus is available as 3 milligrams, 7 milligrams, and 14 milligram daily tablets. These medications should be taken first thing in the morning, 30 minutes before eating, with at least 4 ounces of water. If a patient also is on levothyroxine, that is also required to be taken first thing in the morning, separated by all their medications. It can actually increase levothyroxine exposure by 33% when they're taken together. So definitely an important counseling point to give to your patients to be aware of or potentially take separately if possible. As you can see here, I've listed the starting dose as 3 milligrams, which is started once daily for 30 days and then increased to 7 milligrams after 30 days, and then may increase to 14 milligrams if additional glycemic control is needed. Ribelsus has been shown to decrease A1C and body weight compared to sitagliptin and empagliflozin, and also helps to decrease body weight compared to liraglutide. However, it has shown to have more adverse drug event-related treatment discontinuations within the trials, so essentially it's not as well tolerated in the trials based on its approval. It's unclear if it is beneficial in MACE. There are trials that show non-inferiority compared to placebo, and also shows non-inferiority for decreasing A1C compared to the GLP-1 liraglutide. So in general, Ribelsus may be a good option to consider for patients that have a strong indication for a GLP-1 and or are requiring better A1C reduction but are unable to administer injections. But if a patient is able to give themselves the GLP-1 injections, that would likely be a better route based on the trials that we have so far. Next, we'll talk about the SGLT2 inhibitors. Again, these agents show up in similar locations as the GLP-1s, as you can see under ASCVD or high risk of ASCVD, in heart failure, specifically only for SGLT2s in heart failure, and then CKD. There are multiple different SGLT2 inhibitor products on the market, including Invokana or canagliflozin, Jardiance or empagliflozin, Farxiga or dapagliflozin, and Stelgatra or artugliflozin. SGLT2 inhibitors work by inhibiting, like the name, the SGLT2 or sodium glucose cotransporter 2 in the proximal tubule. So here you can see the location of the proximal tubule in this graphic. And inhibiting this transporter prevents the reabsorption of glucose and thus increases the excretion of glucose in the urine. So essentially, instead of reabsorbing that sugar in the blood, through the kidney filtration system, the patient will pee out the glucose instead. And as this glucose is excreted, then the blood glucose levels will decrease. The efficacy of SGLT2s is a little bit lower compared to GLP-1s at about 0.4 to 1.1% reduction. Their place in therapy is for patients with established ASCVD or high risk, specifically the SGLT2s with cardiovascular outcomes, and then using them in patients with CKD to decrease CKD progression, and then lastly for patients with heart failure. Here is a better list of the different SGLT2s I previously mentioned, including their initial dosing and their max doses, and wanted to point out in particular renal adjustments. So these medications can also be used more recently in patients with heart failure without diabetes. However, there is different renal adjustments based on what indication you're using it for. So if you are starting a patient on an SGLT2 inhibitor within the diagnosis of diabetes and another comorbidity like heart failure or ASCVD history, then you're going to follow this renal adjustment. So for example, if you're starting a patient on empagliflozin or Jardiance, you can start it as long as their eGFR is greater than 45. You may also notice that it's not as clearly stated here, but SGLT2 inhibitors are tablets, which is an advantage for some patients that may be needle phobic and not able to administer a GLP-1 and maybe cannot afford Ribelsus or is not a good option for them. So SGLT2s have that advantage as well. So SGLT2s have evidence in different categories. As I mentioned before, there are different indications. So it's important to know which particular agents, as not all of them have the same evidence. So for cardiovascular benefit, per the guidelines, they recommend the drugs that have cardiovascular benefit in clinical trials, which includes empagliflozin, dapagliflozin, and canagliflozin. For patients that you would be starting it for the heart failure benefit, that would be dapagliflozin, canagliflozin, and then empagliflozin. However, empagliflozin is the only medication in this class that doesn't have primary outcomes for decreasing heart failure hospitalization. It is only in secondary outcomes. Also want to note that empagliflozin was recently studied to show a reduction in heart failure hospitalizations in patients with HFpEF or preserved ejection fraction. This was in the Emperor Preserve trial from 2021. However, it's not currently FDA approved for heart failure with preserved ejection fraction. The ADA guidelines made an update in 2022 that broadened the recommendation for heart failure patients rather than specifically for reduced ejection fraction, and they just generalize it. So that kind of opens up the decision to consider using it in HFpEF patients, but know that this is not a current FDA indication. Next, we have the drugs that have renal protection outcomes or helping to prevent the progression of chronic kidney disease in patients with diabetes, specifically with albuminuria. And this again is these same three drugs with empagliflozin having secondary outcomes. And then on the bottom here, also included the fact that for weight loss, SGLT2s also help to promote weight loss. However, they don't have as significant weight loss benefit compared to GLP-1s. And then lastly, they also help to lower hypoglycemia risk as they don't increase that risk in patients as long as they're not also on some type of medication that promotes insulin secretion, like an insulin basal or bolus injection or a sulfonuria. SGLT2 inhibitors' mechanism of action that I explained earlier helps to also explain its common side effects. So if patients are excreting higher levels of glucose or sugar in their urine, that increases the risk of having the genitourinary infections. The increased excretion of water with glucose can also lead to dehydration and hypotension, especially when a patient is already at risk, such as during an acute illness. It also increases the risk for DKA, mainly during hospitalization, and the risk of hyperkalemia. Bone fractures has been a concern for some of these medications, specifically for canagliflozin. They have been reported to occur more frequently. However, other SGLT2s may also reduce bone mass and increase bone fractures. There was a meta-analysis of trials evaluating this safety outcome that didn't show an increased risk of fractures with dapagliflozin or empagliflozin. So at this time, more of the risk is specifically for canagliflozin. Amputations have also been observed in all three of canagliflozin, empagliflozin, and dapagliflozin drugs. However, the new cardiovascular outcome trials of SGLT2s did not show an increase in amputations, and likely this is because patients were monitored more closely with foot exams in the trials and were discontinued on treatment if risk factors presented. So it's just important to keep in mind that patients that are on SGLT2s should have close monitoring with diabetic foot exams as closely as possible when indicated. And then lastly, bladder cancer can be seen in all SGLT2s, mostly with dapagliflozin from the clinical trials. So if a patient has a history or currently has bladder cancer, then this would be contraindicated. To reduce the risk of DKA, it's important to counsel these patients on SGLT2s if they experience any kind of nausea or vomiting that limits their oral fluid intake to then hold the dose of the SGLT2. You can also consider the need to adjust any kind of diuretic doses to prevent dehydration and hypotension. For AKIs, it's based on the trials, you should expect a slight increase in the serum creatinine with initiation of SGLT2s, similar to the small increase from ACE inhibitors or ARBs. However, it will help to prevent the decline of the serum creatinine over time compared to patients that were not started on an SGLT2. I won't go through this slide in detail, but just additional information for you on DKA risk factors and ways to help prevent it from happening in the first place. Just important to keep in mind for patients that are on an SGLT2. This is also just for your information. I mentioned that expected decline in the serum creatinine initially. So these are graphs of the eGFR from the different SGLT2 trials. And as you can see, the eGFR declines initially more rapidly than placebo, but then over time, the patients that are on the SGLT2 maintain their eGFR compared to the placebo group, which has a greater decline in their eGFR. So thus it helps preserve the renal function of these patients when they're on these drugs. Next, we will go into the rest of the medications that are available for treating diabetes or additional add-on therapy that you can consider based on different factors. The class of drugs that we'll talk about next is DPP4 inhibitors. DPP4s have a couple benefits pointed out in the guidelines. So they don't have a risk of hypoglycemia, so it'd be reasonable to add that on in patients where you are concerned about having low blood sugars. And also they are weight neutral, so it's appropriate to add on to a patient's regimen if they are already overweight and you're trying to help either promote weight loss or at least avoid increasing their weight. So DPP4s, or dipeptidyl peptidase 4, is an enzyme that inactivates incretins, which include GLP-1 and GIP, which works similarly to GLP-1. Thus, these drugs inhibit DPP4 and prevent this enzyme from inhibiting the incretins, which leads to an increased effect of incretins, which leads to inhibited glucagon release and increased insulin secretion and decreased gastric emptying and decreased blood glucose. Note that because these drugs work similarly to GLP-1s, they generally should not be used together with the GLP-1 receptor agonist class. The efficacy is also pretty good, 0.5 to 1% reduction in A1C. They also help to reduce the postprandial and fasting glucose levels. Overall, they're pretty well tolerated for adverse effects, and they have shown in trials to increase heart failure hospitalization, specifically for the drugs saxagliptin and alogliptin, so those specific medications should not be started in patients with heart failure. The DPP4 inhibitor drugs are listed here, including their initial dosing and applicable renal adjustments. So unfortunately, DPP4s have not shown in clinical trials to have any kind of similar benefits like the GLP-1s or SGLT2s do. However, they are a good option for patients that may need additional A1C lowering. They're also tablets similar to SGLT2s, so definitely is something you can consider in patients that may need additional A1C lowering. Just keep in mind that heart failure risk for some of these drugs, as well as avoiding using them with GLP-1s at the same time due to their similar mechanism of action. Next class we'll talk about is sulfonurias. As you can see here, sulfonurias come up under considering cost and access, as they have been on the market a really long time and are very affordable compared to these other agents, which are still brand name only. However, they also have some downsides, including increasing risks of hypoglycemia, so that's why it's not recommended in that category. And they also increase the release of insulin, as I'll discuss on the next slide, so they're not helpful for patients that are trying to lose weight or at least stay weight neutral. Sulfonurias bind to and close the potassium channels on the cell membranes of pancreatic beta cells, which depolarizes the cell by preventing potassium from exiting. This depolarization opens the voltage-gated calcium channels, and the rise in intracellular calcium leads to an increased fusion of insulin granules with the cell membrane and therefore increase insulin secretion. So in general, you can think about it as they help increase the insulin release from the pancreatic beta cells. They are pretty effective and help reduce the A1C by 1 to 2% and decrease fasting and postprandial glucose. However, they are not often sustained past the first few years, mainly because their mechanism of action relies on functioning pancreatic beta cells, which decrease the further a patient has diabetes. They also have significant adverse effects, as I've alluded to, including promoting weight gain, hypoglycemia as they promote insulin release. They also cause GI upset, may cause a rash, and hematologic potential side effects. There is strong caution with any initiation and dose titration in patients with renal impairment. Here are the available sulfonurias. The max effective dose is actually half the max dose listed here, and higher doses just lead to more side effects without additional glycemic benefits, so I would not recommend going to the absolute max dose, but rather half of this max dose, because you're not going to get additional benefit beyond that. It's also recommended to titrate up slowly at 1 to 2 week intervals, mainly based on the patient's blood sugar. The medication should be typically taken with the biggest meal of the day and about 30 minutes before a meal. Remember that these increase insulin secretion, so they should not be taken if the patient is not eating a meal, as that would lead to a low blood sugar. Glimepiride has the highest risk of hypoglycemia, mainly due to its longer duration of action, and dose adjustments are required in eGFR less than 60 to 15 and should be avoided if the eGFR is less than 15. Glyburide has weekly active metabolites which are cleared renally. So patients with reduced renal function may experience accumulation, which can significantly increase their risk of hypoglycemia. Thus, glyburide is not recommended in patients with CKD or any kind of renal impairment. If a sulfonuria is needed in an older adult, glipizide is the best choice due to its shorter duration of action and less risk of accumulation in reduced renal function. Dose adjustments are required for eGFR less than 50 and not recommended when less than 10. Next, we'll talk about the TZD drug class. TZDs have also been on the market for a long time and are available as a generic in a low-cost form, so can be beneficial in patients with cost barriers. They also don't have significant hypoglycemia risks, so may be beneficial in patients where you don't want to or are concerned about a risk of hypoglycemia. So TZDs act by activating PPARs, or the peroxisome proliferator activated receptors, which is a group of receptors specific for PPAR gamma. When activated, this leads to increased gene expression to increase the storage of fatty acids in the adipose tissues, thus decreasing fatty acids in circulation. Cells then become more dependent on glucose for energy and thus increase the insulin sensitivity in the body, which is ultimately its action and helps to decrease blood glucose. Generally, it improves insulin sensitivity in skeletal muscles, liver, and adipose tissues. It also decreases hyperinsulinemia, and it does not increase insulin secretion itself. These are also generally effective by decreasing the A1C by 0.5 to 1.5% and decrease basal and postprandial glucose. Its benefits include no risk of hypoglycemia and no renal adjustments needed. It does require monitoring of LFTs and regular eye exams. There are two TZDs, including pioglitazone and rosiglitazone, and I've listed here the initial and max doses, and again, there's no renal adjustment required. A big reason why TZDs are not as commonly used compared to other drug classes is due to the multiple different adverse effects, cautions, and contraindications. Firstly, it has a black box warning for heart failure exacerbations and is contraindicated specifically in New York Heart Association class 3 through 4, and I likely would not recommend using it generally in heart failure if there are other options available. Other side effects include edema and also the downside of weight gain. There is some concern for bone fractures. And then I mentioned the monitoring of LFTs with hepatotoxicity. So it is recommended that patients get a baseline LFTs and periodic LFTs based on this risk, which was from a prior TZD that's now removed from the market that had severe hepatotoxicity, including death and liver transplant. There hasn't been any hepatotoxicity specifically observed in trials for the current TZDs, but it's still a precaution recommended by the FDA. There's also a potential risk of bladder cancer, specifically with pioglitazone, so it's recommended to avoid in patients with a history or currently have bladder cancer. Next, there is risk of increased cardiovascular disease and LDL, specifically with rosiglitazone, so it's recommended to avoid patients with cardiac history or high cardiac risk factors from being on specifically rosiglitazone, and oftentimes people may avoid just the drug class in general. And lastly, for a risk of macular edema, this has been reported with some of the TZDs, including rosiglitazone, and usually this presents as blurred vision or decreased visual acuity. Most patients have peripheral edema at the time of diagnosis. So patients should at least have regular eye exams every 1 to 2 years, and diabetic patients especially have a higher risk of retinopathy as well. So it's important to make sure that patients that are on TZDs are getting these regular eye exams. This slide is just for your information. There are many combination products in the market that may help with promoting adherence for your patients that are already on multiple agents to reduce their pill burden. And that's the end of the slides that I'll go through. I have some additional slides of less commonly used drug classes just for your information in case you encounter it in clinical practice, but are often not used today to start for diabetes patients. And I hope that this lecture was helpful, and I appreciate your time in listening.